maybe Matt, that's a good segue to your discussion, which is, as you mentioned, a lot of patients we see in clinic would, would not have made it onto EV301, for instance, right? For instance, patients with variant histologies, we wouldn't know what the outcomes are with enfortumab, and that's where, some of the abstracts you discuss will.
Yeah, and so there were two abstracts that our team, so Tanya Jindal was the first author and did a remarkable job of basically pulling from this, again, very large set where we have, just over 600 patients. And the first abstract was looking at patients with any degree of variant histology mixed in. Bladder tumors are in some senses at times similar to non-seminoma germ cell tumors in that they can certainly be mixed, which is a little bit different than what we see oftentimes in kidney cancer, where it tends to be more likely to be pure. And when we see these mixtures, we can see squamous uh, features or differentiation. We can see adenocarcinoma, we can see micropapillary, we can see plasmacytoid, we can see small cell. There's a large number of these variants, and most trials will be designed in a way where if it's the urothelial component has to be predominant. And they often will have exclusions where if there is presence of small cell will be excluded, for instance. And the challenge is we end up at times on the abstracts that are sent later, when they talk about variant histology, it tends to be a very small percentage. And the question is that actually driving the tumor or is it not driving the tumor? So there's a lot of unknowns here. There have been studies that have been purely focused in variant histology, but again, they tend to be small, tend to be single arm. And so what this effort really was set out to do is how does EV perform in these? And so there was 150 patients that had at least some variant histology. We then broke it down into was the variant histology predominant, which meant at least 50% of the tumor was that variant histology, and then pure. The pure was actually a very small number. It was about 14 patients in total. The predominant was larger. But basically, what we saw, which I thought was important, was in some of our hardest to treat variants, and plasmacytoid to me is one of the worst of the worst. This is a tumor type that loves to crawl along the peritoneal cavity, loves to cause bowel obstructions, loves to crawl along the pleural space and cause pleural effusions. And these patients go downhill very quickly. And we saw in patients that had mixed plasmacytoid a signal that there appears to be activity with enfortumab vedotin. And I thought that that was a very nice signal to generate. Jeannie Hoffman Census a few years ago had put out a paper showing that Nectin-4 is plasmacytoid does have staining in a good portion of patients, and so perhaps a way forward there. On the kind of further end of the spectrum, in terms of small cell, we didn't see any activity in a small number of patients with small cell. So I think, again, when patients have mixed histology with small cell, I don't think we should necessarily jump on the bandwagon and say that these are perfect patients for an EV strategy, at least initially. And we should really continue to hone in on chemotherapy and other potential options for those patients and not necessarily go down that road. Again, Jeannie Hoffman Census had basically 0% Nectin-4 expression in small cell neuroendocrine. So that's the subset we're still working on. The other abstract was looking at squamous, which is one of the more common subtypes that we see. And again, it was squamous presence, predominant squamous, and then pure squamous. Again, relatively few patients with pure squames. The pure squames, we did not see any responses in with, but again, it's a very small number. But as there were more and more squames, the percentage of response went down, the progression-free survival went down, the overall survival went down. And that really, I think, should make us think about as we're trying to evaluate how to treat these patients with variant histology. I think we have some leads where I think targeting Nectin-4 is important and potentially combination are going to be important. But there's other subtypes where I really think we need to, again, kind of come to the drawing board together and figure out the best strategy, what the best targets are for those variants.
Yeah, that is an excellent summary. And yeah, I think this was a very, interesting population to look at, and I wonder whether any of this data surprised you. Well, you, Matt, or either of of you guys.
Yeah. I mean, to me, I think this data is very exciting and important, as Matt highlighted. To me, the squamous abstract actually was a little bit of a surprise. If you think about, but it's not not a surprise from what we see in the clinic. It kind of mirrors what we're seeing with the clinic, but it's a surprise in terms of squamous histology. Relatively, if we think about it, close to the skin, and histology and high expression of Nectin-4. And we see that when we do IHC and in multiple efforts, squamous does have high expression of Nectin-4, but this brings it down also to the resistance to enfortumab vedotin question. Is it loss of the target, that brings in the antibody, or actual resistance to the payload?
Yeah.
And it may highlight that in squamous, the payload is what's driving the resistance. And again, it's hard to drive too much conclusions from small numbers, but to me in the clinic, the pure squamous histology represent an area of need in the field overall, and they, still need areas to discover more regimens.
Yeah, there's a very interesting point, and then this is actually primary resistance to EV, right, or to EV payload, as you're hypothesizing. Matt, along the lines of what you said, it was a good surprise actually that the plasmacytoid patients that we saw some responses, right? Are there any other variants where maybe that you would highlight?
Yeah, I think adenocarcinoma, there were responses, and as we saw today, I think we're all learning about, we've, I think, historically lumped urachal and adenocarcinoma into the same group. And I think, biologically there are some differences between urachal and adeno, and I think we're learning more and more. And so as we continue to, I think, gain more and more cases, I think we're going to be able to tease out a little bit more as we go along. But these have historically, especially, again, not very many pure adenos in our series, but these have historically been more challenging to treat patients, and variant histology, bladder remains a huge area of unmet need in our field, and it gives me excitement that we have a lot of agents entering that can be potentially evaluated, but a lot of work still to be done.
Yeah, for sure. But potentially some early signal that we can consider enfortumab, or maybe even enfortumab vedotin combinations with pembrolizumab for some of these patients.